Hi, I'm Dr. Noel Wagner, Saginaw-Tuscola Medical Control Authority. Today we're going to talk about the two sensors that we use the most in EMS, the pulse ox and the CO2 sensor, and just kind of straighten out a few of the misconceptions that people have on them, as well as some of the things that we should be using them for. So first, let's talk about pulse oxes. Pulse ox is probably the greatest invention ever given to emergency medicine and EMS. It's a great way to tell what your oxygen level is. Back in the old days, which is probably 30 plus years ago now, the only way to know somebody's oxygen level was to do an ABG, which was difficult in the emergency department and impossible in EMS. So the fact that we have a device now that we can just slip on somebody's finger and find out what their oxygen level is great. We just have to keep a couple things in mind whenever we're using it. The first thing is how to use it properly. And that usually comes back to making sure you get a good reading. And a lot of this centers on people understanding or misunderstanding what the pleth wave means. The pleth wave is what we see on the pulse ox screen. It's the sine wave looking wave that comes through. And what that is that's checking the blood flow essentially. It should mimic your pulse rate. And if you have a good pleth wave, that means you should have a good reading because the flow is good across the sensor. What that should tell us is that when there's a bad pleth wave, the reading may be unreliable or inaccurate. Not guaranteed to be inaccurate, but it definitely could be with a bad wave. With a good wave, that means the reading should be reliable. It should be an accurate reading. Now, the problem that I see some people running into is they will give a low reading. They'll say, oh, the pulse ox was 85%, but there's a good pleth wave. And that's a complete mismatch of what the pleth wave is supposed to be telling you. If you have a good pleth wave and a bad reading, you have a bad reading. Okay. And I'm not sure where that got lost along the line with some of us when we're looking at that. So keep that in mind. A good wave is an accurate reading, and the accurate reading may be good or bad. Okay. So don't let a good pleth wave somehow justify that a pulse ox reading is good. It's just accurate. Second thing about pulse oxes, high readings are not always good. Now, I say not always. It's good to have a high reading. You definitely would rather have a pulse ox of 95% than a pulse ox of 65%. Don't get me wrong, oxygenation is a good thing, but it's not always the best indicator if somebody's in trouble. You can have ventilation issues like asthma. Asthma is a classic one. You can have a very good pulse ox reading until you die because it's not an oxygenation issue. Asthma is not an oxygenation problem. It is a ventilation problem. So a relatively healthy set of lungs, as far as the lung parenchyma, can still be oxygenating quite well, even though you can't move a lot of air through it. And especially if we put somebody on oxygen, they can be teetering on respiratory failure with a very, very good oxygen reading. So keep that in mind that a high reading isn't always as reassuring as it should be. Again, it's better than a low reading, but it can be misleading, especially if we put somebody on oxygen and we've just kind of tided them over for a little bit. So keep that in mind. And then the other thing on pulse ox is everybody probably remembers this one, but you can get false readings, and the most classic is carbon monoxide. All the pulse ox is reading is it's reading how well the hemoglobin is saturated. So carbon monoxide will saturate your hemoglobin just as good as oxygen, and the standard pulse ox can't tell the difference in that. So that's the classic false high reading on that. So hopefully those are some things that are helpful with pulse oxes. Keep in mind the big take home: don't be misled by what the pleth wave is telling you. CO2 readings. Very useful, much more useful than oxygen, than pulse oxes for telling somebody's respiratory status or their ventilation. So in that scenario we had you on before with the asthmatic, asthmatic on oxygen can have a very high reading, but if we actually have the CO2 hooked up and we're reading their carbon dioxide levels, we may see that their levels are rising because they're not moving enough air. When you're not moving as much air, the air that comes out is going to have a much higher CO2 concentration. So that could be a problem. So CO2 is going to pick up on respiratory failure much quicker than an oxygen reading, especially if we put the person on supplemental oxygen. So keep that in mind. The second thing that I want people to remember about CO2 devices, and that's entitled CO2 or the color metrics, you have to use a CO2 reading device for any time there is a tube in anybody's airway, whether that's an endotracheal tube, a King airway, a combi tube, an iGel, an LMA, whatever. That air should be coming from their lungs. If the air is coming from your lungs, it's coming from the patient's lungs, you will have a CO2 reading. If you don't have a CO2 reading that is consistent with a live person, then the tube is in the wrong spot. King Airways, for example, everybody likes their supplemental airways. Well, King Airways says they have a 96% success rate, which is good. But when you do the math, that means 1 out of 25 is not going to be in the right spot. Okay, so 1 out of every 25 times you're in the wrong spot. You have to have the CO2 to be able to tell where that is, and you have to act on it. I have shown up on scenes in the past where people have the CO2 device on and they have a reading of 4. That's not consistent with a person who's alive or has just recently gone into cardiac arrest. Okay, low CO2 readings are a sign that the air is not coming from the right spot. So you have to act on that. So the big take home on CO2 devices is, 1, use them for knowing if somebody has impending respiratory failure or actual respiratory failure. And 2, you have to use them on all airway devices that you've used. It's one of the reasons that we don't use them on our medical first responder units. There's no science that shows that the outcomes are any better than bag valve masking, and the amount of equipment and training that would add on to that it just make it a very, very difficult endeavor for us to do. So hopefully that's useful on pulse oxes and CO2 detectors. And until next time, like I said, I'm Dr. Noel Wagner, Saginaw-Tuscola Medical Control Authority.